here, and the others can join later. So now we want to talk a little bit about cultural sensitivity and identifying approaches to data collection and reporting that are culturally sensitive. How do we do that? Well, again, we're going to go back to those stakeholders. The people who will be making the decisions and the people who will be affected by the decisions, program staff, program partners, target population, secondary users, need to be involved in the process. The CDC tells us to create a diverse advisory team with help that will help with planning, implementing, and interpreting findings from the evaluation. And we have to do what the CDC says. So what do you want to do with your stakeholders? Well, you want to have them help you decide what measurements to do, decide what survey content should be, design questions, help you figure out what are appropriate survey methods, do pilot testing, and understand the results. And it's crucial that you have some stakeholders from the populations you're trying to reach that we know everything we need to know, but we don't, right? We really don't. So I really depend on stakeholders. The other thing we're going to do is we're really going to train our data collectors. So interviewers, no matter what, must be well-trained. They need to be well-trained in interviewing techniques to not show expression, etc. But they also need to be trained in the culture of the population or subpopulation that they're going to be working with. You can ask people from the target population themselves if they would like different types of interviewers. What types of interviewers would they like? And sometimes they don't always want an interviewer from the target population. So we had a time when we were working with a certain group of men who had sex with men, and they said that they actually did not want a person who was another man who had sex with men doing their interview. I don't know why, but they wanted somebody else. And sometimes some things you want a person of the same gender, and sometimes you might not want a person of the same gender. You need to provide cultural sensitivity training, and education about the target population and the community culture. And you also need to be very careful about having confidential spaces where other people cannot overhear what you're doing. And use anonymous methods if possible. Now, what do we do at the IPH? So at the IPH, I'm kind of lucky because I work with community-based agencies, and they are really the experts in their populations and experts in what they're doing. So I just need to walk in with a mindset that I'm always ready to learn, and I try not to assume everything. I always assume that they know better than I, depending on certain topics. I might know more about evaluation, but they're going to know more about everything else, right? So I ask a lot of questions. I defer to staff judgment and target population knowledge whenever possible. We work on translations a lot together, and we also work on are the questions culturally sensitive and culturally appropriate. And a lot of times, like I said, the people I work with are experts. And then we also do pilot testing. Sometimes we use existing patients or clients from another similar program. Sometimes the agency has a community advisory board made up of people from the different target populations, and we have them go over the questions first. And we definitely get staff and stakeholder input to help us explain and interpret any results we get. Because if something doesn't look as good as you thought it was supposed to look, you know, if you were supposed to hold 10 classes and they only held 8, I have no idea why. They need to tell me why. They need to tell me what the difficulties were getting participation, etc. And sometimes I work with frontline staff, management, or clients to help me figure things out. And then I'm going to have some partners give an example of how they engage stakeholders within their agency. So we can start with Lori. Did you know about this? So you have 5 minutes, or 6 or 7.
So the county has an initiative. The county has an initiative called Getting to Zero, and that we're talking about getting to 0 new HIV infections, and we want to have no new infections. And we have a planning body, the HIV planning group. Because we get funding for care and treatment from the federal government, from the Health Resources Services Administration, HRSA, we have to have a mandated planning body. And then we also get funding for the Centers for Disease Control and Prevention. And we used to have two bodies. We sunset both, and now we have one body. And there is a committee called the Strategies Committee, the Getting to Zero Strategies Committee, and I chair that committee. I want to say we've been trying to get clear on our strategies to get to zero new infections. And if you remember, I think it was in 2010, the former administration put out the first ever national HIV/AIDS strategy. There had never been one before, so that was exciting for us. They did an update in 2015 where they put indicators, like these are the 10 indicators that we're going to measure to make sure we're getting to zero new infections. And they, I mean, everything is now different with the current administration. There's now a new initiative called the End the Epidemic Initiative, and they're going to be funneling a great deal of money. I think right now we're applying for a grant that could bring us up to $4 million a year for 5 years. You only have to apply once. It's not like you have to apply every year. Most of our funding sources were applying constantly. So those indicators we took on locally. How are we going to measure these things? And there's about, we kind of committed to 9 of them as part of our Getting to Zero strategy. So not all of them can we measure yet. We're still working on how to get PrEP uptake data. I was talking to the gentleman about, how do we find out who's taking that pill, Truvada? How do we get prescription data? People sell data, and we don't want to buy data, of course. So whether we know how many people we need and want to be on PrEP, I think it's about 10,000, and we maybe think maybe 3 are on. So I'm just using this as an example of how we engage the stakeholders. Would be people living with HIV, people impacted, or maybe people that are vulnerable to HIV, people on PrEP, to participate in our community planning, and those folks give us input. I think that's the example.
Perfect.
Okay. The life stories is there, but, oh yeah, let's look at it. Can we go back to 50 and I'll show them the life stories, just because that's the example of the data?
Yeah.
Okay.
Yeah, it's like
Oh, it goes like this for every word. Okay, so I did. It's not a touch screen.
that's what I thought.
Let's see if this opens. So have any of you guys use life stories? Anybody here heard of or use life stories? I really, really like life stories. I don't want to do it as a profession, but when I had assistants, and Lisa did some assistance with me, that's her home invitation, we're going to be getting to zero. We took those measures, and I was saving this for the end, but it's relevant. The committee is using these outcome measures, these 9 indicators from the National HIV/AIDS strategy, to look and see how we're doing every year to get to the game or the sum goal of 2021 was the end that we were looking at. Well, we can't see now. Maybe you figure it out. Oh yeah, that looks like it. There it is, objective 1. So, getting to zero. We have a campaign, a local campaign that's, how do I move it down? These don't work, do they?
I know.
It's way over on the edge.
Oh, yeah, use this. Okay, so one of our objectives is to reduce the people that are unaware. That's the people that don't know they have HIV. When I started this work over a dozen years ago, we thought probably 4 out of 10 people didn't know they were living with HIV. Now in San Diego, it's about 1 in 10. So we're essentially looking for needles in haystacks. That's an interesting analogy. We want to, and you can look at these over 5-year increments. So we started in 2014, and it looks like where we want to be in 2021, like we're on track. I think we may have another year's worth of data that hasn't been entered. We want to have fewer people get diagnosed with HIV, and the goal is to reduce it by 25%, and we have reduced it by 26%. We've already met the goal of reducing new diagnoses. We want to make sure people get linked to care within 30 days. It used to be 90, then it was 30, and now we're actually trying to get people in treatment the day they get diagnosed. So same day rapid linkage. It's a new pilot we've practiced over the last couple of years, and You know, it may take a couple days, and some programs do it differently based on people's health needs, but we're getting people linked to care, so the goal is to get over 85% linked to care within 30 days, and we're there. We want to increase retention care. This measure's got some problems because it assumes you have 2 appointments within 3 months, within a year, and people are going once a year. So what we really want to see is viral suppression. Let me look at that one. We want to see that people that are viral suppressed, that means they have less than 200 copies of virus in their body and they can't transmit it. There's an international campaign called U equals U, which means undetectable equals untransmittable. Means if your viral load is undetectable, you cannot transmit the virus, which is awesome. It reduces stigma. It lets people that are HIV positive, that are virally suppressed, know that they can be sexually active and not transmit the virus. So that's pretty exciting. We want to get viral suppression up to at least 80%. We're right on our way up. We're really doing well. We want to reduce death among people living with HIV. This is a bizarre measure because people could die of anything. So we decided instead to look at late diagnoses. That means people that get diagnosed late in the disease will oftentimes get simultaneously diagnosed with HIV and AIDS within a year, or they're sicker when they come in. It's a late diagnosis. So we want to get early diagnosis, and so this using live stories as a way to project out the data has been something Lisa's helped me with as evaluator, get the data in the system, and I kind of like it. It's visual and it's kind of fun to use. Instead of a PowerPoint, you know, death by PowerPoint. So there you go. Get back to.
Thank you, Lori. And now Lucky Reyes is going to give us a few ideas of how she handles engaging stakeholders and cultural sensitivity within her organization. And we'll try to get back to the slides.
Good afternoon, everyone. One of the examples that I thought about was for hepatitis C. We offer hepatitis C testing in various locations in the community, and it's a rapid test. We get results within 20 minutes. But we have noticed that there was a time where our rates were higher and people were not coming into their care. So what we did is we did a needs assessment that helped us ask more questions on the whys. Some of the things that we asked is, why aren't you going to care? Is that priority? Is it because of location? Is it because of insurance? Is it because you're just not ready to get into care? The feedback that we got was a little bit of everything. Some people didn't know that you can go into care if you're still using. Some people didn't know where to go and access care. So we were able to provide more information and share this with our providers. We currently at Family Health Centers have 8 different locations where we have providers trained to offer hepatitis C care, and that was very helpful to have. We're also part of a lot of different community meetings where we have consumers who have completed their treatment and they're able to help others on how to get into care and how to talk to their partners. I'm also part of the hepatitis C elimination with San Diego, and we have our provider, Dr. Reimers, who has been a champion in all this here, especially in the San Diego area.
Thank you. Okay, now we have a few minutes to open it up if anyone in the audience has any experience with cultural sensitivity and wants to share anything for the group. We can let you share that, or experience engaging stakeholders and how that works or doesn't work well.
We do a high school survey. Hi,
She'll
everybody.
do anything for you.
Thanks. My name is Barbara Colgates, and I have a local community organization called Lean and Green Kids, and we give presentations in high schools. And we had a survey, and we have only gave them a checkbox for male and female. And we got a note from a high school student that said, please add NB for non-binary. And we did. And then we got a note that said, thank you for adding this from a completely different student. So anyways, that was just recently, but I feel like at this point, that's probably pretty standard, yes?
Well, it should be, and it's coming more and more, but you'd be surprised at the places that it's not. You know, I'm sure California is a little more advanced than the rest of the US in that, but we are always learning from the LGBT center here. Whenever we do surveys, we'll be like, oh, they came up with another gender category. And it happens. So we've now and we had focus groups with the people from the state that time. So right now it's currently male, at least on our forms, male, female, trans man, trans woman. Some people add queer on there, some people add non-binary on there, and other. So, and then of course for us in the HIV field, what we really need to know is what gender you were assigned at birth also, not only your current gender identity, because we need to figure out about specific risks. So, but yeah, that's a really good point. Does anyone else have any information or experience they'd like to share?
Just real quick, I'm just thinking now we might change it instead of male, female,
Maybe instead of changing it to male, female, and be maybe identify as, and then have, and so that,
yes, that it covers all,
I think that might cover all our bases.
Yeah, it's friendly that way.
Hi, I just wanted to share maybe a slightly different perspective. I'm not professionally, but I was on the board of the San Diego Children's Choir for many years. And we recently went through a big evaluation, which was headed by like a qualitative evaluation and had quantitative data after it. But the most interesting thing that happened to us was when we were building logic models and theories of change and kind of looking at what we thought the impact of choral singing was on the young people as a part of our program, we realized during our very long, in-depth interviews that we were bringing a lot of our value judgments into that evaluation. And when we sat down and we talked with our youth participants, and these were like 45-minute interviews done by board members and staff, very different outcomes came out of their mouths, and the things that they prioritized were different than the things that we prioritized as a board. And so that was not a specific culture, but more just youth culture, I guess. And it was really instructive for us that then when we did build the surveys, they were more reflective of the actual outcomes that the population felt was important, as opposed to what we as board members sort of wanted to be important.
That's a really, really good example, and right now we are part of it's an assessment about people who inject drugs in San Diego County, and we think that that is going to happen, and we're very excited to find out, because we are asking providers and key informants, what do you think are the greatest needs? But then we're going to ask people themselves who are current or past injectors, and we're interested to see on how those line up and how different they are. And hopefully we've got the right interview crew where we're getting some good information, but yeah, it happens and it creeps in all the time. And it's like you almost need those people to tell you, hey, you've done this wrong, hey, you've done this, hey, I felt this way when you did that, you know, and it's really important to encourage that, right? Encourage that feedback, encourage people to tell you what they think about how it's going. All right, so now we're going to have Letty Reyes come back up for a few more minutes to talk a little bit more in depth about cultural competency and her agency.
So at Family Health Centers, I'm going to be talking today about HIV counseling and testing. And through Family Health Centers, we receive different funding source, and that comes from the state, the county, federal, CDC, and also private. Our personnel goes through a lot of intensive training. The training for basic one is to become a certified counselor, and that is through the California Department of Public Health. The training consists of completing different modules before they go into the training, making sure that they pass with an 80%, and then going to a 5-day training. The training consists of being able to ask open-ended questions, to reevaluate the risk assessment of every individual they're testing, to make sure that they're, have referrals available and that they're able to disclose an HIV positive result or a negative result. But before I go on, can you guys raise your hand and tell me who knows what a rapid test or has heard of a rapid HIV test or hepatitis test? Do you know where you would refer a client or a patient to get tested? How many of you guys know where to refer? So the county has a website for you guys know, and if you click in HIV testing or hepatitis testing, they'll give you a list of locations in the county of San Diego where you can refer someone for free testing for HIV and hepatitis. We are at Family Health Centers testing both at community clinics and within our clinics and also at, out in the field. And out in the field, that would be at community events, churches, bathhouse, parks, colleges, universities, bars, anywhere where they're required to do, where they're asking us to provide testing, we're there, as long as we have a private place where confidentiality is being kept. Identifying new HIV positives. In the past year, Family Health Centers has been able to increase the numbers of HIV positives that they have identified. Our goal when we identify someone is to get them linked into care within 1 week. But recently, I would say, well, in the last 3 months, we have identified about 15 clients, and out of those 15, we were able to link 10 people into care within 24 hours. So that has been a great success. We received funding from the county, thank you, Lori. And we've been able to do rapid testing within the community and continue to learn from our lessons and improve our services. So our goal again is to get them linked into care within that week. To support our internal and external providers, we created a IT report, working with our IT department to see what else can we do different. Because there were times where we were missing that positive and not so much the provider, but the counselor. So we weren't being told about, hey, there's a positive diagnosis, can you send a counselor over, that way they can help with the process with the linkage to care. So we met, we got approvals from our CEO, from our providers, we met and we came up with a plan. So now we get a daily report, and it's only a day behind, that tells us anytime there's a presumptive positive and a confirmatory positive. This has helped us tremendously. Why? Because it prepares for us to know who we're gonna send to disclose and help the provider. There's a lot of ongoing communication. We created an email, internal email, so when they do have someone, they can send an email or they can call us. So we working with IT, we were able to do a direct line where it rings on all of the desks at our Lemon Grove location, and there's always someone ready to take that call and send someone over to whatever site. We have over 22 sites internally, but we don't only provide the service internally, we also work with Planned Parenthood and other private providers. So anytime we get that call, they'll ask and say, who can you send over? We have someone coming in tomorrow at 11. It's a female, it's a male, this is their status, and can you come in? So that's our part. Once we disclose, we first let the provider disclose, then we take the time to do any referrals. And the referrals may be to mental health, if they're homeless, if they need housing, if they don't have insurance, alcohol and drug services, and other supportive services. Once they attend their first appointment, our goal is to make sure that anytime we're giving that result, that the counselor makes that connection with the client and that we go with them to their first appointment. And we have seen that this has been a success for us. We get the opportunity to introduce them to the clinic staff, to who their case manager is gonna be, and if they need any other services or referrals, that can be from dental, vision, and STD clinic, if the person is pregnant, if we're gonna be sending them to UCSD, and just assuring that we make that first connection. Also, a big component is if they need transportation. So we have transportation that we offer, and again, it's just being very client-centered and assuring that we provide the best care for that individual. So lessons learned. Somebody mentioned Excel document, and love Excel documents, but throughout the years, I figured this is not working for me anymore. The Excel document that I created for HIV positives, we've been using for the last 10 years, and every year or every 6 months, we were adding something different. So as I mentioned before, we recently got more funded to do rapid testing and linking people into within the 24 hours. And we asked the county, hey, you guys are asking for more data. Can we receive funding to hire Lisa and do a new database that will create reports in a faster way? And they agreed, they gave us the funding, and now we have an amazing database that will tell us into detail. And I'm sorry I don't have pictures here, but I can just show you from here. It just gives you all the details. When the first person went to their first appointment, when they took their first pill, when they attended their case manager appointment, what worked, what didn't work. If they didn't attend an appointment, then we work with the county. If they didn't get a result, then we work with the county, because the county will send someone out to field to look for that individual if they have not received their results. So I would say our biggest lesson learned would be to ask questions and always go back to your funders and say, this is what we have, it's working, it's not working, can we add, can we get your permission? And at times they will say yes, and at times they will be like, no, this is what we need. So it's being able to work and ask your staff, the people that are doing the data entry and collecting that data, to see what works and what doesn't work. Thank you. Questions?
Thank you, Letty.
Thank you for your presentation. I appreciate that. That's a lot of work for everyone who's been speaking on the second part. A lot of this data is extremely important, and one of my questions, I don't know whether it's part of the stakeholders portion, but how is your data including certain age brackets? Is it over a certain age, under a certain age, or is there consent into that, minors, guardians, all that? I think I did hear that you were using homeless and non-homeless, so that answered one of my questions, but I kind of wanted to know, how did you come about getting the age involved with who you were surveying? Was it everybody? Was it certain people?
So our age, for rapid testing is 13 and older. So that's the age group for testing.
Okay, welcome back. So we got a nice little bridge here into our next piece that we're going to be talking about, but I wanted to reiterate that test counselors are very, very, very trained to be culturally sensitive and culturally appropriate, as Letty explained. But in addition to that, at Family Health Centers, a lot of their employees, especially that works with clients, receive motivational interview training, and also
Ongoing updates on STDs.
ongoing updates on anything, on everything, and cultural competence, you name it, it happens all the time. So.
First aid, mental health, lots of mental health.
Oh yeah, mental health training also. So, now we will go on to data collection. This is fun. Data collection is great, right? Okay. We have until 3:25. 2:30, so we're good. All right, data collection. We're gonna look at a lot of different data collection methods that people may or may not use, and it really depends on your funding source and your program, what you're gonna do. So of course you wanna collect data according to your evaluation plan, and often you can collect data electronically or through paper and pencil. I don't know if there's another way, that's all I could think of. You may have logs, you may have surveys, you may have interviews, etc. that you're collecting. So this is a review for us right now, right? We've already talked about all of this. You want to be sure that you're storing data appropriately, especially if it's got sensitive information on it. It needs to be in locked cabinets or encrypted drives, etc. And you also want to keep it organized, because someday maybe somebody else is going to want to come and enter your data somewhere if you're not entering it already. sometimes there's lost surveys, sometimes there's lost bits of data, and you hate to see that happen. So keeping it organized is good. When we talk about data security and data confidentiality, you may or may not be a HIPAA entity. Has everybody heard of HIPAA? The Health Information Portability and Accountability Act. I think I did that correctly. So if you're a health care provider, you are a HIPAA entity. If you receive data from a healthcare provider, HIPAA applies to you. So you can read about it and figure out whether HIPAA applies to you or not, but whether it does or not, the items that you're protecting, we need to all live by those same rules, right? To protect client and patient data. So if you have any identifiers present, and they have a list of all the kinds of things that identify a person, along with health data, then that is considered HIPAA data. And things that may be surprising to you is an email address plus a health question is HIPAA data if you fall under the purview of a HIPAA entity. If you have a 5-digit zip code and a health question, that may be HIPAA data. It's safest to use I can't remember if it's the first or last 3 digits of a zip code, or to at least look up the rules about that zip code in that area to be sure that it's okay. If you have a date of birth and a health question, that's HIPAA. If you have dates of service, of medical service, that's HIPAA. And so you really need to be careful with HIPAA data and where you enter it and where you store it. And we'll talk about where you can collect it and how you can store it in a little bit. So what is this idea of data coding and entry? And some of you are already very experienced on this, and some are not, but we're just gonna have a tiny little primer for a few minutes. So you need to sort your data and get it ready for entry. And if you have forms that are not complete, you need to complete them and put them in piles so your data entry person knows what you're doing. And you may have different places where you enter your data. It could be in an electronic health record, in an existing database, in an Excel sheet, in a customized database, or you might not be entering it anywhere and you might be hand counting data. You have to determine who will do all that, and if you're using a computer, is it on a network where more than one person can use it or not? If you are going to use an electronic health record or an existing database, your number one question is, does it have all the data elements you need? And often in our case, it doesn't, because we're doing things that are demonstration projects, they're new projects, existing data systems don't cut it. So then you might ask, can that system be modified to meet our needs? If you must work with a non-modified pre-made system, then you may as well back into what you're gonna measure and use what's available in the system. Or if not, if you have to measure some things that aren't in that system, then you're getting to where Lori was talking about, where we've got 2 different systems because we need to measure some things that aren't in this system. Or in the case of one of the databases we use, the online database is like a black box. We don't get anything out of that system. So we have to have a second system to help us when we have our monthly reports. So Excel. Excel can work just fine to enter. Most people have it. If you do use Excel for data entry and you want your data to be somewhat clean and easy to use, look up a little primer on how to create drop-down boxes in Excel, because it will really, really save you. You could actually have somebody choose yes or no instead of typing in yes, space Y, yes, etc., and then you can't summarize it later. For a customized database, which could be Microsoft Access, SQL, or any other type of customizable database, SurveyMonkey, etc., which is not quite a database, but RedCap is. It is often the best solution for data quality, but it can be more expensive. And the reason why it's a good solution is you can do data quality checks between different data that are entered. Here's a little grid, and this is just based on my own experience. A database is excellent for data entry. You can get very clean data on entry, and you can have a database have reports and queries and things programmed into a database to spit out what you need. So as Letty was saying, it can be a very, very useful tool. However, you need to have somebody who knows how to program it, and you need to, and it can be costly. And you also, if you hire somebody to program it, you have to be able to interact effectively with that programmer. And I say that with affection because I program also, but you have to be very specific and you have to know exactly what you want, or you're going to get something different than what you wanted. With Excel, I primarily use Excel for graphing, although it can be used for a lot more than that. I have used it sometimes for data entry and created if statements and different cells and stuff like that. But for me, I find it easy to mess up your data accidentally. I try to sort something and it just doesn't sort it all together and I have to go back. So what about statistical programs that you hear about? SPSS, SAS, Data, R, etc. Some are free, some are quite expensive. They are the easiest way, if you have one, to do data analysis. So in Excel, you can count how many yeses there are and you can count how many no's there are and program that in. In a statistical program, you just say, give me a frequency of that. So it really depends on what you need it for and what you're trying to do. I have, but I wouldn't necessarily enter directly into a statistical package just because you can't even do the same safety checks that you can with Excel. It's just straight data, you better be careful. Here's an example of each. The data page of each looks the same. The difference is that when you have a database, you can have more than one table and they can be related. So you can have a table of client demographics, and then you can have a table that has 25 visits per patient. So it's a little bit different when you get into a relational database, and of course you can have a pretty entry page, which I am told you can do with Excel. I just have not done that. Has anyone here done that, made a data entry screen in Excel? So it can be done, right? And it can make it pretty and use different colors. Right on, that's what's important. Okay, so what about coding? And what is coding? Coding is often, it can be taking data and making it into numbers so that we can analyze it in a statistical program. But it can also be taking your qualitative data and figuring out how to put it into different themes. So data coding means different things. But depending on how your system is set up, you may not need to know the codes that are behind your data. You may or may not need to know them. If you're entering into a database, you don't need to know what the variables named and what the codes are. It will show you right there. I'm going to show you some examples in a second, but in general, a variable name would be what you name the variable that you're going to enter, and coding would be yes or no, or a 1 for yes or a 0 for no. And for qualitative data, when you're coding qualitative data, there are different ways to do it, but if you have already gone through your data and come up with some themes, and you know the themes that you've got, you can actually have a data entry person enter the data, and then if you've got a variable for each of the themes, they can put a 1 in each of the themes that apply to that data they enter, so they're kind of coding it as they enter it. Data entry is often, but not always, just for our purposes, is 1 row per survey or per person or per visit, and the variables are across the top, labeling the different columns. Text or qualitative data should be entered verbatim so that you are not interpreting it on the way in. After entering a survey or record, this is just one of those little best practices. It's best to mark something on that survey or record that you entered it, and if at all possible, something that's in your data sheet or your database. So databases can be set up to give you a record number, and you can write that on your survey after you've entered it. In Excel, you could do a line list of 1 to 100 and enter that number. And that way, if you do have a question later when you're cleaning data, you can go back and reference your original data source if you have it in paper. You may not have a paper data source. You can enter data online on a computer, in an entry device, you can scan it. Scantrons are still a thing. There are price points with using Scantron services, but I worked with a program once who they collected 10,000 surveys every so often, and thank goodness that they had those on Scantron forms and scanned them in, and then we just got the data in an Excel format. If you're doing research or rigorous evaluation, you might double enter data and then have a system that can check and see if you've made mistakes on entry, and we often don't do that with the things that we're doing, although like Lori said, we do have methods to clean our data and check that the things are in there and compare it between the systems. So this is an example that you can kind of almost read, but people talk about code books all the time. Well maybe they don't. People I know talk about code books all the time, okay? So what is a code book? So a code book is something where it's gonna talk about in your database, here's the question you asked, here's what we called it in the database, and here's how we coded a yes is a 1 and a no is a 0, etc., right? And a lot of times the code books are in Excel, and they give you some more information. What was the data type, how many spaces did it take up, etc. And what I do, and so, oh yeah, you have it on a handout if you would like to look at it if this isn't clear enough. What I do is I actually take the codes and I put them on the data collection form itself. Because for me, that's very visual, it's very easy to look at, and it reminds me when I'm interpreting the data to go back and look at the exact question that it came from. So that's what I do, and I can tell, oh, I put a 1 there, I know it's a number field, right? So that's often enough for me. This example on the other side in purple is from one of the HIV testing forms from the state, California Department of Public Health. And you can see their coding on the page. They've got a 1 for male, a 2 for female. They still use transgender MTF, that's kind of old school, but you know, it's better than nothing. What they don't have is the variable name, so you don't know the variable name, but it's very interesting to me because they put the codes on this, and sometimes if you had an entry person, they would actually use those codes to enter, and enter a 1, 2, 3, 4, and 5. But they have the codes there, but they don't have you do that. They actually have drop downs where you select male, female, etc. So, but it's nice to be able to see their codes, I suppose. So Excel, what kind of things do we want to do in Excel? So this is a data entry sheet, it's a log, and it's user-friendly, and when at all possible, you want to make your data entry screen or sheet or whatever you're using look exactly the same as the data collection form, if you use forms. And this example, somebody made this, and I really love those little check marks. I don't know how they did it, but if you move the data anywhere else, the check mark counts as a 1. So you can see on the bottom where we summed it. We summed the number of rows. And I like this sheet, and we use it sometimes. However, when it comes to, say, something that's mutually exclusive, like age group we've got here, there's nothing stopping a person from accidentally marking 2 age groups. And then you've got a cleaning problem with your data. So how could we stop that? And there, I didn't give you a test, but I could have, because we did talk about this a minute ago. But you would turn that into a drop-down menu. So if you had a drop-down menu, then a person could only choose one of the items in the list. And here's a different example of an Excel sheet that Lori and I used for PrEP navigation. PrEP is the medicine that you can take to prevent yourself from getting HIV. And we have, like, this field here is a yes/no field, and it's a drop-down. These are calculated fields. We calculated how many days between something happening and when they should call them for a 3-month checkup. And if you're interested, there's really a lot you can do in Excel, and you can be like me, I just look things up online, how to do them all the time. I watch little videos. People put videos of everything online these days. So I say, well, I wanna know, I've got a column and I have it written in male and female, how can I find out how many females there are? Well, you can make a new cell and you can put that little if statement at the bottom and it'll count for you how many females there are. So, and when I've seen it done, well, like you'll have a tab where you enter your data, and then you can have a different tab that summarizes data from that first one and either graphs it or gives you some frequencies. And if you're doing a thing that you're gonna do the same thing over and over and over, you can create that for yourself and then erase the data and put new data in and get your new results. So these are just here for your reference. They're things I've had to look up recently to do that sheet. Here's just a screenshot of Microsoft Access where you've got your little buttons of what you want to enter and you've got your different entry places, and that was just to show you that. There's different things you can do, and this is an example of a report that could come out of any database, and you maybe, if you set your data up right in Excel, could have Excel pop this out for you, but it's not gonna pop it out for you in the same way. So with a database, we have you put in the dates that you're gonna start and end your report on, and it populates the report for you. And this one happens to do some pretty intense calculations on the back end, where it's like a reduction in days experiencing mental health systems is really a summary of 5 different questions. And it has some ands and ors in there. So this is just to show you what's out there. Now, what are you gonna do? Say your data is entered and you want to clean it and do something else with it. So it seems odd that I made a whole slide about backing it up, but it is so important to back things up. So you want to back it up before you clean the data, and you want to back it up after you clean the data, but before you analyze it. And you would be surprised how many times you mess things up when you think you're cleaning the data. You're making it better, but you've actually done something wrong and you have to go back to your original data. And you want to enter it on a computer that's backed up. And you want to be careful about entering sensitive data on the internet, unless it's in a HIPAA secure system. So remember we were talking about that. Do you want to collect certain survey data on SurveyMonkey? SurveyMonkey is not a HIPAA compliant system. So we had some people recently who wanted to collect from transgender individuals their zip code, their date of HIV diagnosis, etc. on SurveyMonkey, and I said, no, please don't do it. They, I think there are ways around it. I think you can get a BAA agreement with SurveyMonkey, but I wouldn't trust it. I would use a different system that's made for that. Or take those items out of the survey, which is what we've decided to do. We asked more general questions, like what year, and we didn't ask zip code or anything like that, so. Cleaning data. How do we clean data? We don't use a vacuum. But we clean it by looking for data, looking for errors, correcting inaccurate, incomplete, or incorrect data. Getting rid of spaces in front of values, applying a similar value to all missing data cells. If you want to, I often just leave it missing. Make sure that numbers that are stored as text are converted to numbers, etc. So when you try to move your data somewhere else, it'll read it correctly. Remove duplicate records, that's actually a big thing. You can fix typos if you want. And make sure that dates are stored as dates. So what do I do when I'm cleaning data? Because this happens a lot in my life. I'm looking for typos, I'm looking for dates that are incorrect, things that are missing that shouldn't be, values that are outside of the possible limits if I didn't do a 100% accurate job at getting it clean on the way in, or illogical data between multiple fields, looking if there's something that, you know, this person said, no, I'm not diabetic, but then they said, yeah, I have to use insulin twice a day. Then I start to wonder about the data. And I always go back to the original record if I can to check the data. So how do I do it? So as Lori was talking, I didn't think to put that on here, but if there is more than one source of data about the same person, like when we have the two systems, I check. I make myself queries and I check between the two systems and make sure we've got the same number of people, the same outcomes, etc. It comes in pretty helpful. Often I sort columns. I'm just sorting a column of one variable, and I'm doing that so I can look at the highest and lowest values, because that's where you're gonna find a lot of mistakes, especially in dates. And then I'm often sorting two or more columns together. I move them close together, and I sort them both ascending or both descending if they are related, so I can look at the data and see. And if I have a ton of data, so if I've got 10,000, 100,000 records, I'm not gonna be doing that. Instead, I'm gonna be using queries and running frequencies and checking the different values, or in a statistical package doing crosstabs for things that maybe should be possible or not. So when we talk about analysis, there's really two different kinds of analysis, and I find that in program evaluation, all we really need very often is descriptive analysis. Frequencies of things, how many yes or no, what percentages out of the total, and averages, such as average age, etc. And then looking at whatever variables we want to look at and splitting it by different subpopulations, age, gender, race, ethnicity, etc. And I put in there a note to double check everything, because you might, well, you just have to double check everything, right? Or you're going to be reporting something inaccurate. You double check your entry, you double check your programming, you double check that you counted the yeses right, that it really adds to the total, and then when you move that into a report, you double check that you put your number there correctly. Analytic analysis is more where we're going to be calculating p-values or other more advanced statistical methods as needed, and it's very useful to do analytic statistics, and it is not always necessary, right? If your audience isn't going to understand p-values, then don't do p-values, and you might be looking more at what is meaningful versus what is statistically significant. Qualitative, what do we do with qualitative data? You can spend a lot of time doing qualitative data or a little time looking at your qualitative data, but in general, it's more work than closed-ended questions. So how do you do it? How do you begin the process? And there are people who do this for research, and I'm not an expert on this. I'm just telling you the basics of how we do it. You read through all of the responses first, all of them. You get your thinking cap on, and you want to start to think about what themes am I seeing here, what comments seem similar, and then you make yourself a list of what are the different categories or themes, and you give them each a label. Then you go through them all again, and you start to figure out how many people are answering similar things. And you also want to count the number of people who didn't answer at all, just because that's useful information. And you want to attempt to identify patterns or associations. Some best practices are using statistical software. There are programs out there, NVivo and others. I haven't used it yet, but I'm about to. And if you do it by hand, which most of us have been trained in because that software didn't used to exist, a best practice is to have at least 2 people do it separately, completely separately. Read through everything, code everything, put things in categories, and then get together and compare. See if you came up with the same categories, and merge your thinking together until you get it figured out. So that's usually how people handle qualitative data. I guess I'll give you an example in a minute. I thought it was on this slide. So what do we do when we have pre and post data? Because this is pretty common in evaluation world. You're only going to look at the same question on the pre and the post test. It has to be the exact same question and for the same person. That's the best case scenario. And then you can look at the number who responded yes on both surveys, and you can look at the number of people who changed from a no to a yes or a yes to a no between your pre and post surveys, for example. And often in that type of analysis, you are not including the people who didn't respond. So they have to respond on both surveys to get included in that. So that way you're comparing the same people at both data points. For qualitative data, You can ask the same question twice, but you don't really compare it pre to post. You can talk about different themes, but it's not quite on the same level as quantitative. Here's an example of if you're really have your work set out for you, if you decide you're gonna look at pre and post data by hand. So here's an example of one question, and it was, how often did you use condoms in the last month? And if we look at Aaron, he says that he had no sex, and then he says that he never used a condom. He started having sex, but he never used a condom. So I might make a column that says change in use and write not applicable there, because he wasn't using condoms on the beginning survey, but he was on the end survey. And then, did he have a positive behavior change? And in this case, positive behavior change means less risk in his life. And I'm gonna say no, he actually has more risk now than he has before. And then I move on to Rebecca and say, oh, she went from rarely using condoms to usually using condoms. That's an increase in condom use, and it's also a positive behavior change. And then I can add up the number of increases and the number of yes, no's. Hopefully you don't have to do it this way, but if you do, you can. These are an example of some tables for pre and post surveys. This is the percent who had an increase, decrease, or no change. And if you want to fill out a whole question, it's the percent who said always on the pre-test and always on the post-test, usually on the pre-test, usually on the post-test. Sometimes even this is too much for an audience, and you might want to split it into the people who, we call it collapsing categories. I don't know if there's a real term for it, but you might want to put the people who, the percent who said always and usually on the pre-test and the post-test and compare that. I often will add a column over here that has the number of people or the percent of people who increased condom use. And I may have one more column on the side that says the p-value, but I may not. Here's an example of a question that is not part of a pre and post question. And I've just got this highlighted because you just need to think about what you're going to do with people who didn't respond and how you're going to include them. And you just need to be consistent. You can leave them all out. You could say I had only 7 respondents, or 9, in this case, 9 respondents, and have it equal 100%. Or you could say here was all 10, and I'm going to show my readers how many people didn't respond. And you can do different things in different situations. Here's an example. And you can't read it, and that's okay. You don't have to read it on purpose. But it's an example of how you might report some focus group and in-depth information. This example is from the CDC. So they did a bunch of focus groups, and then they put their findings into facilitators and barriers for each of the identified themes. So that would be a proper way to report qualitative data. This is something I often do, and it's not quite as proper. But especially if I have a survey and it's got an open-ended question on it or a short answer question on it, I might actually come up with my response categories or my themes and count how many people responded in each response category and report that. You will find people that go a step farther and put percentages on those, and you really shouldn't. I wouldn't go farther than this, just because it was qualitative data, it wasn't quantitative data. I'm sure there's debates about that. So what are some common problems that I find? This happens a lot, not so much anymore, but it used to happen to me more, where somebody would hand me a pile of pre and post tests and I can't match them on participants. What do you do? So if they handed you 100 pre-tests and 100 post-tests, and they said, I am sure that these are the same people, but I just can't match them, you can still analyze them. You cannot do that thing where you look at the people who said yes on the pre and yes or no on the post. You can't do that, but you can do a straight frequency and compare the two because you've got the same people. But if they hand you a stack of 50 surveys and a stack of 100 post surveys, and they'll say, well, we're pretty sure these 50 are these in this 100, what do? You really can't. You really can't compare the two because you've got so many different people in the two groups that it would be meaningless to compare them. So you just have to report them separately and not conclude a lot from it. Or you could look at analyzing only the post survey and and gathering what you can learn from that. And say, oh, we got this post survey from all these people and they seem to know X, Y, and Z. So that is the life of an evaluator, in case you hadn't realized by now, is figuring out what to do when things are less than perfect. So, sometimes you collect information, you collected way too much and it won't be used, and you want to try not to do that, but you don't realize until the end that you're not going to use it, and then you're sad that you put everyone through that. Sometimes you didn't test the instrument well enough and you can't interpret the results. That has happened to me. It can happen to anyone. Sometimes the logs, you made logs and it doesn't collect all the information that was needed, or what was needed changed. It happens quite a bit. One important thing is employee buy-in or comfort with the data collection tools or system, and related employee turnover. So if you say, I have this smashing database and it will do everything for you and give you the reports and track your data and give you lists of things you need to clean, but you have an employee who doesn't like to use databases, you need to do something, right? You need to figure it out and help them. And I did have one instance where I made a beautiful database and the person wanted it, so that's why I made it for her. And she managed her program and looked at the data and used it and kept it up to date. It was beautiful, running perfectly, and she left. And somebody else came and took her position. And that person wasn't really at that same level. She didn't like to track it that way. She was a little bit afraid of databases, and we tried different training programs throughout the year. But then in the end, we said, you know, we're going to go back to you tracking things by Excel or by hand because this system isn't working for you. So you really have to gauge things based on what people will use and what people, you know, sometimes you can force people to use things, but sometimes you can't. And then sometimes you're at the end and you realize that you thought you made this super fabulous measure, but it's not exactly easy to measure or as easy to measure as you thought. And we'll look at an example of that too. And this is just a general report. I'm not going to go through the different sections, but if you're making a formal evaluation report, you would have all of these sections in it. Sometimes my reports don't have a discussion in it because I'm giving results to people and I really want them to interpret what it means. But a full report would be like this. But that doesn't mean that that's the same report that you're going to share with your whole audience, right? This is a report from the county website where this is more of an infographic, and that will be more appropriate for different audiences. And there's this website that I learned about at a HRSA meeting called canva.com, where you can do this for free yourself. You can plug in data and it makes it all beautiful like a social marketing expert did it for you. So now we are going to move into interpreting results because I, kind of messed up the thing a little bit. And we are on time. So this to me is one of the most interesting things to think about, and we often have no training in this. How do we interpret all the data that is thrown at us by the media, day in and day out? Well, the first thing you're going to do is refer back to the exact question and how it was asked, because that is the only way to interpret your data. Woo, that's why I made it do that. And when you report data out, if possible, use the full question and then report the information about it. So that way your reader knows exactly what you asked and exactly how you asked it. And you didn't summarize it and assume the reader knows what you mean, so you don't lose a little bit in the interpretation there. Questions that you're going to ask yourself are, what did you learn? What were the limitations? Who took your survey and who did not? And how did they differ? In what ways does the data suggest your program was successful? Were there different results for different subpopulations? Are the results what you expected? And can you justify your summary with results? And then you're going to display it in different ways. You can use graphs, tables, text, infographics, PowerPoints. You're going to tailor it to different audience. And you're going to use statistics, meaning p-values, etc., that your audience understands, or statistics in general. So here's an example of a knowledge-based question, and I think this is real data from a class, a parenting class I think it was, where we've got the number of tests, the number of pre-tests, the number of post-tests, the mean score of each, the change in mean score, not the percentage change in the mean score, and a p-value. And that is perfectly fine for a report or different variations thereof that you might see in a report. But when we reported this out into the community, we changed the format and we said, let's look at each of the different sessions and let's make a bar graph of the percentage of people who learned something from each of the 4 sessions. So you want to break your information up into things your audience will like. And I've been going to different presentations about that, about presenting your data and doing it effectively. And the statistics on the amount of information that you retain visually versus reading it, and the amount of information that you're drawn to visually, and the amount of information that keeps your attention is just so incredibly different that visual is the way to go, is the take-home message on that. So basic tips about interpreting data: you want to ask the stakeholders to provide their interpretation first. You want to make conclusions only based on your data. You don't want to look at your data and then go on and on about something else that you think is happening. You want to focus it on your data. Use statistics your audience will understand, and don't panic if your findings aren't everything that you want them to be, because you're going to use them to improve or modify your program or inform somebody else who's going to make your program a lot like yours. So negative results are good. They help somebody else know what not to do or help you know what you need to improve. And you want to interpret your results with the goals of your program, biases, and external factors in mind. So an example of external factors, especially if you don't have a randomized controlled design on your hands, is that say I had a program and I wanted to teach people how to have safer sex. And then I measured them and everyone had way safer sex behaviors after than before my little class that spanned about 3 months. But at the same time, this PBS special came out on TV, which may never really happen, and it was a big hit and everyone watched it, and it was a 5-session series for 5 hours about teaching people about how to have safer sex. How am I going to know that what they learned was from my project or that outside influence? So you always need to think about that too, what's going on in the world around you. So you need to know, what does your audience want to know? What are the limitations? Are there alternative explanations for the results, not just your program? How do your results compare to other programs? How do different data collection methods support a single result? So for instance, if a person says, oh yeah, I practice, you had 100 people and they all practice safer sex, great. But now let's do a test also of them and find out if they have a lower chance of getting HIV, that none of them got HIV compared to some other population. Now we've got 2 different things pointing to the same result. And are your results consistent with theories supported by your research, and are they what you expected? So here's our first lovely example, and this was a real question on a real survey that I made. And it was like maybe my first year. Do you think the following would put you at risk of HIV? And here's our results. We've got the people who said yes on the pre and the people who said yes on the post, and there wasn't a lot of change, but there was some change. But the more I started thinking about it, I said, I'm not sure what people were thinking when they answered that question. Were they thinking about general knowledge, like this is a knowledge question and these are the things that put you at risk for HIV? Or were they thinking about, are they doing these behaviors and putting themselves at risk for HIV? So this illustrates why you always have to go back to your original question and ask yourself, was it worded carefully? Did it make a lot of sense? Here's an example of a measure that you come to at the end, and it had an and in it. Remember how I said don't put ands in your questions? Well, don't put ands in your measures either, if they make you measure two things. So in this example, we've got a certain percent of clients with follow-up contact will adhere to their plan and reduce their alcohol use. So we had 100 clients, 50 adhered to a plan, 40 reduced their alcohol use, and those overlapped with only 20. So if we were answering this objective exactly as written, we could only say 20% of the people adhered to their plan and reduced their alcohol use. But if we had one objective about adhere to the plan, we could say 50% of the people adhered to the plan. And if we had another objective about alcohol use, we could say 40% reduced their alcohol use. If we had put an or in there, which I don't recommend, but if we did, then look at that. We've probably got 90% of the people who adhere to a plan or reduce the alcohol use. And that's not a good objective to do that, but you could do it. 90% of clients in the program will report an increase in knowledge. So the question with that, I call it the of whom problem, is what's your denominator? If your denominator is everybody who enrolled in the program and you had attrition of 40% in this case, you've got a problem. You're not ever going to be able to show that 90% of the people who enrolled in your program had a knowledge increase. So in this example, we've got 60% of the people stayed to the end of the program. Of those 60 people, 55 had an increase in knowledge. So if I had used a different denominator, I could have said 55 out of 60, and that would be above 90%. So in that case, I would have wanted to say 90% of the people with a post-test, or 90% of the people completing the program, and then that would have been a better objective. So you want to be careful when you're writing grants and thinking of those things ahead of time. Another thing that can trip people up is when you start to talk about the percentage of increase, or an increase by X percent, is to be exactly specific about what you mean, because that's a little bit open to interpretations. If you wanted to have something that said, for instance, persons who complete X services will realize a 10% decrease in alcohol as defined as, you can imagine in your head, I can probably measure that, right? Like if I ask them on the pretest if they drank 10 drinks a day and now they drink 9 drinks a day, that's a decrease. So that's okay, I'm gonna use it there. But sometimes what I really wanna know is 80% of the people who complete a program will have a decrease in mental health systems. And that is, you can imagine that's even easier to measure. I just need to measure a decrease in 80 of the 100 people that I served, and it makes sense to me. So this is just a note to be careful when you use the terms percent and increase together, that you really know what you're getting yourself into. Now we're going to talk a little bit about interpreting data findings. And these to me are the interesting slides. So I don't know if any of you have heard before that correlation does not equal causation. It's really, really true. It really is true. And so many of the things that we hear reported to us day in and day out are correlations. They are not causation. You can determine causation by experimental, randomized controlled designs with a control group. Then you can find out if something really causes something. You can, with observational studies, which are all other studies, also get close to figuring out about causation, and there's a good article that I have here somewhere, anyway, in the slides that talks to you about doing that. But in general, if you have a correlation such as children that watch TV are more violent, you really can't say much about that. All you can say is it happened, but it could be that the TV caused the violence. It could be that more violent children watch TV. It could be that some other factor acted upon them, or it could be a coincidence. So you really don't know. You just know they're together. And this one right now is my favorite, about diet soda being linked to weight gain. So does diet soda cause you to gain weight? Or as you're gaining weight too, do you decide to switch to diet soda, right? and so you really don't know. Or is there some other factor at play here? And it may be a real relationship. So it's like you can't discount it entirely, but it may not be. And there's a pretty famous study about women and hormone replacement therapy. There was more than one, and it was one of those known facts for quite a while, where women taking hormone replacement therapy had lower incidence of coronary heart disease, and they really thought this was the real case. And it turned out that this is not the case, it's the opposite. And what happened was they found out in the data they were using that women that were taking hormone replacement therapy were more likely to be from a higher socioeconomic group, and that had a bigger influence on coronary heart disease than the hormone replacement therapy. So you really have to be careful about deciding whether something caused something else, if you, depending on your survey design or your study design. So what about selection bias? So selection bias can the data that you collected apply to other people that you didn't collect it from? Well, you have to be really careful about that. There are lots of different kinds of selection bias. There's sampling bias, attrition bias, survivorship bias, non-response bias, self-selection bias. And an example of that would be, I had a professor and he would say that this was the day of mail-in surveys, he would say, you know, the people who submit the first surveys, the first 10% of surveys you get, and the people who send in the little stragglers at the end, the last 10% of the surveys you get, it's like, there's something different about them. They don't explain the average person. So sometimes they throw those surveys out, sometimes they don't. And I said, wow, what does that mean about me? I sent it in right away because I love doing surveys. So anyway, there's all different ways how data that you are collecting may not be applicable to other people. If you have a program of 100 people and half of the people didn't make it to the end, and you surveyed the people who did make it to the end, then the people you can really talk about are the people who were successful in your program, had X, Y, and Z happen. But you can't apply that to the other people in the program. You don't know what happened with them. So that gets to the question of who took your survey and why, and who did not take your survey. And that's the article you can look up from the NIH if you want, that talks about this stuff. So what do you do? There's another example I have. We did a survey of people with HIV, about 5 years ago, and then another one about 1 or 2 years ago. And you like to compare these results over time, right, to see what's happening. It's not of the same people, but it's a community-wide survey. Well, the problem is the survey is not a random sample. Anyone can complete the survey. And the first round of surveys was completed with paper and pencil by people at different agencies that serve people with HIV, handing out the surveys. The next time the survey was done, it was mostly done online. People completed it online. And it turns out that these people weren't the same at all. They weren't close to being the same group of people. So, and when you just looked at demographic characteristics like age, gender, race, ethnicity, you couldn't tell that they were different. So how they were different was socioeconomic status. That income level made a big difference, and it influences all the different answers. So now what happens is you can't really say, this tells us all about men who have sex with men, or this tells us all about men who have sex with men. It tells us about the people who took the survey, right? It doesn't mean the information is not useful and it can't point us in other directions, but it doesn't mean that all of the men who have sex with men in San Diego County are this way. It needs to be just couched that way and used appropriately. So you might talk about, and evaluators are really good at this, of the people surveyed, of the persons in the program, of the persons who completed the program. These results may mean this. That's the kind of stuff that you need to say. What about missing values? If you have too many people didn't answer a question, then you can't have that much, you can't believe in that question that much, and you might talk about only those who responded. Sample size. Everyone talks about sample size. At least everyone I talk to talks about sample size again. So what is sample size and how important is it? So it really depends on what you're doing. If you have a specific question that you need to answer, and you need to show that your program had this amount of change Now you're talking about being able to do a sample size calculation, if you know the power and stuff like that, and say, oh, well, we need at least 200 people to prove this with a p-value. But aside from that, you may not need to care that much about it. It really depends on what you're doing. So I'll give you an example. I had a group of people and they collected 3,000 surveys every time they collected surveys from churches all throughout San Diego County. And when we went to analyze the results, and they collected it over a series of years, there were changes. Everything was statistically significant, every darn thing, because we had a sample size of 3,000 for one year and 3,000 from the other year. So what we decided to do is look at meaningful differences rather than the p-values. So you need to make these decisions when you're looking at your data and interpreting your results. Is it a meaningful difference? That may be more important. What about unstable estimates that you might get from Ask Chiz or things like that? So an unstable estimate means that it's not really a good point estimate, right? It means it was made on one person and we're inferring a bunch of information from a response of one or two people. So do you use it? Do you not? Do you not? Ask Chiz recommends against using it, but it really depends on your purpose. If you're using it just to explain something, fine, but if you're using it as a benchmark that you're going to measure changes off of, probably you shouldn't do that. You need to look for something else. What about a needs assessment? What kind of sample do you need for a needs assessment? So a needs assessment, you're setting out to find information and gather information, right? And I've worked on some programs where the CDC said, oh, well, figure out what your population is and sample 10% of them. Whether you're doing a random sample or not is a different question, but just make sure you get 700 of them. So I was on a project and we had to sample 200 people every 2 years for this ongoing needs assessment. But I had a professor and he told me a bit of information that I kind of live by. So say you went out there and you really just want to find out what people are thinking, what are they doing, what do they need, and you collect 100 surveys. A good question to ask yourself would be, am I going to get any new information if I collect another 100 surveys? And if your answer is no, then you don't need to collect that other 100 surveys. Do you have enough information with what you gathered to act on is actually more important. So let's see, oh, we're doing good with time. We have 3 more minutes left. So justifying conclusions, I'm not going to read the other slides after this one, but justifying is determining what the results say about your program. They are judgments about, is your program, what is the program merit, is it worth it, etc. And how do you decide if your program is justified? How do you justify your conclusions? You're going to compare it to a bunch of other sources. You're going to look at your past performance, you're going to look at other similar programs, you're going to look at literature, you're going to look at your benchmarks, all to help you judge if your program was successful or not. And you can read all those slides on your own, or you can go to the CDC and read them. Let's talk a little bit about sharing results. We talked some about this already, but dissemination involves communicating evaluation procedures and lessons learned to relevant audiences. Here are some common methods. You can have your big old evaluation report, but you can have mailings, websites, community forums, etc. And of course, you're going to tailor your results to each audience. And I just wanted to get to the place where I showed you this, and this was a marketing person who introduced me to this idea, is that you can actually have a plan for sharing your results. You can have a dissemination plan. And you might find more or less complex plans online, but you have an audience, you have the format that is most appropriate to them, and what effective channels you're going to use, and you come up with this as an agency and you have a plan of how you're going to disseminate your results. So I want to let you know also that we've prepared a comprehensive resource guide, that this presentation and the comprehensive resource guide will be available online to you after the presentation with hot links and the kinds of things that you're going to find also online. Here's a picture of our resource guide, and here are some blank forms that people can use to help them fill in the different parts that we talked about today. And we have 5 minutes for questions. Or else you can go. So wait, I should have done that because then you won't ask any questions, but.
Questions for Lisa?
Do we have questions? Or comments, or?
I just thought this was very useful. You collect all this data, and it's data, and then you provide us some tools of ways to interpret. So I wanted to thank you for that. Can't wait for the research guide.
Woo, thank you. Thank you very much.
Lisa, excellent presentation. Thank you so much. Quick question. So in my experience, I typically come across people who either love data or don't, right? And we rarely meet, at least I have rarely met people who are kind of in between. So people who are not very, very data driven, how do we help them understand the value in what we're doing and engage them earlier on in the process and hopefully have a higher adoption rate earlier on in the process instead of convincing them as we move along?
So I think there's some different ways, and maybe some of you even have some better answers, but in the beginning, I kind of set out why we're collecting it and how important it is, and there's that old adage in medical care that if it's not documented, it didn't happen. And so if you want to prove what you're doing and prove your results and show us what you're doing, please document it. Other things you can do which are not, you can have rewards for people documenting their data. You could be more punitive and put it in part of their, their plan for their employment that you have to do this and this. But another thing that we say always needs to be done in evaluation is when you start to get some results is you need to share it with your data collectors because that helps them see the value of it and why it's important. I don't know, does anyone else have any other ideas about how you can help people love data if they don't love it already?
If I may, I'm Elizabeth Russo, by the way, from Health and Human Services Agency. I think that is the question, especially when we're in the community engaging those voices that we really want to hear from. And I don't have all the answers, and I'm a work in progress myself, but I'm thinking what has worked pretty well in the past for us has been right from the beginning asking community stakeholders, what is it that you want to know? I mean, there's parameters, there's projects, there's parameters, there's some stuff that are going to be the non-negotiables. Okay, but there's also some area for negotiation. In addition to A, B, C, and D, we want to hear from you. What matters to you? And can you please help us in the design of getting that information? And then it just builds to the greater partnership and collaboration. And the other piece of it is we can gather all the data, we can do all the evaluation, but another hard lesson is that if you want to continue to keep people engaged, it's critical that they be able to see their narratives, their stories, in this work. Because one narrative builds on another and another and another, and I think that's really the inclusion part of it.
Yeah, I really love that. And you made me think of something else also, which, so say you're collecting data for a purpose, and everyone always wants to find out something else, or at least the data people do. Well, what about this, and what about this, and what about this? And at some point, you need to say, actually, no, we've got enough. We have enough to act on. We have enough to move on. Let's move instead. Let's try some things and see what works. Or, this is an interesting book I read just recently, that you can dwell forever and ever on the things that don't work and why they didn't work. But maybe a better way to look at things is to look at, among all these things that didn't work, you have this success story that worked. Let's examine that and what happened and what they did and see if we can learn from that and replicate it. So, yeah, thank you for your answer.
Great presentation.
Thank you. Any other questions? Okay.
Well, please join me.
Thank you.